Good morning, everyone, and welcome to episode 4 of Add Water and Stir. I'm a little off camera. This morning, we are going to be talking about closing the deal with a dental sleep medicine patient, doing an examination, and we'll give you a teaser for next month. So without any further ado, we don't have any coffee this morning because we are in a patient treatment room, but we're here with the same morning cheer.
Well, good morning, everybody. I'm Stephen Greenman. I'm a diplomat of the American Board of Dental Sleep Medicine, and it's great to be with you all again. We've kind of honed in on the actual patient contact throughout our talks with you, and so today I want to talk about, how do you close the deal? I mean, what do you do when you've got a patient who's here and is interested in what we do? They've had a sleep study. So what are the steps that you take when you go through the interview with the patient at this point and the examination, etc.? So hopefully I won't step off camera too much. Nicole might kind of keep an eye on me and push me around a little bit, but let's get the ball rolling. So I did make a few notes, okay? So when we bring our patient into the operatory, one of the first things we want to do, and can you hand me that chart over there, please, Nicole?
Absolutely.
After we've talked to our patient and introduced ourselves and gotten to know them a little bit, is ask them about their sleep study. And here's a sleep study right here. And the first few questions I ask is, has anybody gone over your sleep study with you? Almost always, if a patient comes to you for an alternative to CPAP, they've never had anybody actually review the sleep study. It's very rare that they will. So one of the first questions I ask is, I see that Dr. Namazi referred you to have your study done, and the interpreting doctor, Dr. Kang, is the sleep physician that went over the study. Did you ever meet Dr. Kang? And the reason I'm asking this is that if the answer is yes to both, then I want to make sure I'm communicating to both for sure, because I want that intro to Dr. Kang, particularly the sleep doctor. And over the years, in fact, I know next week I've got 1 or 2 referrals from Dr. Kang, who's a UCLA sleep physician. So then the next thing I do is I talk to the patient about their sleep study, and I kind of have a sequence that I'll go through. I'll tell them, hey, your diagnosis in this case is for severe obstructive sleep apnea. I'm sure you know about the consequences of that, but do you know what your index means, your apnea-hypopnea index? Of course, the answer is no. Well, your index is 33.5, and I can tell you that means that 33.5 times per hour you either didn't breathe or breathed inadequately, where your oxygen levels dropped to a significant degree. The other thing I'm going to go over is the oxygen saturation parameters, and in this particular case, we'll look for that and as we go further into the study here. You spent 73% of the sleep time with an oxygen saturation below 90%. 90 is the cutoff typically in a hospital setting, where if it went below 90, the alarm would go off, the nurse would look in. So we're talking about 73% of your sleep time below 90, and you can imagine the consequences to your heart, your organs, your brain, to be starved for oxygen for 73% of the time that you're asleep. So those are significant numbers. The other parameter that I like to talk about, or I think it's important to talk about, is heart rate variability, i.e. cardiac dysrhythmias. Now, in this particular case, your pulse went from 40 beats per minute and it spiked up to 90 beats per minute, and it yo-yoed up and down frequently. Your heart is supposed to slow down when you go to sleep. You're supposed to have a restorative period when you're sleeping, so you can imagine the effects of your heart over time if it's not getting the rest it needs at night. And then lastly, I talk about snoring. And not all studies will have snoring information. Some of the better home sleep study, this was a home sleep study I'm looking at today, will have that information. Some of the home sleep studies will also have body position. It's not on here, but those are some of the other things that I like to talk about. So once we've concluded that, I do like to discuss what's the difference between an oral appliance and a CPAP. And to do that, I really, really like a little mannequin device, and it's, I just want the bottom part. It's totally low tech, but I really like it because it demonstrates in graphic form what's happening. So I explain that, well, and again, you can delegate this whole part of it if you want to. That's certainly fine, but I think the doctor touch is nice, and I think you should be dressed nice lab coat and tie like I am, because it does lend gravitas to your discussion with your patient. So we talk about sleep apnea. I explain to them, well, you fall asleep, most of the time the worst sleep apnea periods are when you're in REM sleep, you're on your back, mouth drops open, jaw drops back, and your airway begins to close. Now, the snore sound is the airway beginning to close. It's the fluttering of the soft palate as the airway is closing, and the apnea is when it closes completely. No air can get in. Now, what does the CPAP do? Well, the CPAP's just a blower. It creates a seal, and it blows air with enough force to overcome the competing external forces that are trying to close your airway. That's all it is. It just keeps things open. The difference between a CPAP and an oral appliance, the oral appliance is like wearing retainers, and what it does is it holds your jaw gently forward and it keeps it there so that your airway and your tongue and your mouth can't drop back and close off your airway. So that's a typical explanation that we'll give to a patient that's having a consultation to move forward with oral appliance therapy. Well, so what's next, Nicole? The exam?
Next up, we have our examination.
Okay, so the exam, if you're just starting out, clearly, you may be using paper forms. I use a digital format called Dental Writer, and that's what I have behind me right here. But what that does is it forces us to go through a step-by-step process so that we can put together ultimately a letter for the physicians, a SOAP formatted letter like you see here. Now, the reason I like Dental Writer is that we see a fair number of patients, and we can Dental Writer will take us through the exam step by step and actually produce a SOAP formatted letter automatically. We can paste in the signature and then either fax electronically or make a copy of the form, whichever we prefer. And so we go through the examination. We check for vitals, okay? And you don't need a real fancy blood pressure system. At least in my training for intravenous sedation at USC, Dr. Malamed discussed how even these wrist monitors, while they're not the gold standard, are quite adequate for what we do. So we'll use a wrist monitor and we will measure the neck circumference. We'll look at the tongue level. We'll look at the Malampati classification. And then we'll go through a soft tissue exam looking for tonsils, looking at down the throat, the size of the tongue, the soft palate, etc. We'll check the nasal passages for patency and symmetry. We want to see those nasal valves opening, dilating when a person's taking a sharp, deep breath through the nose. We want to see all of that. We will look at the hard tissue, particularly the hard palate. We want to see a nice, is it narrow and vaulted, or is it nice, wide, hard palate? Of course, if it's a new patient to you, you need to do a screening, at least a dental screening, to look for any significant dental disease that might preclude making the oral appliance. So those are the first steps that we go through. And then we also want to go through a basic TMJ, TMD exam. So we'll ask the patient, hey, you ever get sore jaws? And I'll also palpate the muscles. What muscles will I palpate? Well, the masseters, the temporal muscles. I'll have my patient open and close. I want to look for, normal range of motion with opening. Is there a deviation? Is there clicking, popping? I want to see them move laterally, side to side, and protrude forward and back. I want to look for that. And we listen for joint sounds. We look for range of motion. And again, I'm not doing precise measuring here. I'm just looking for normalcy. And then, of course, we'll check off within normal limits on our TMJ exam. If we do have some findings, we want to note them. We know that oral appliances do not make oral TMJ conditions worse. But we also want to note that it is there, and we want to take certain precautions and maybe construct our appliances in a way that's going to not exacerbate any of those conditions. So, once we finish the examination, then the next step, if all systems look like a go, and in our case with this particular patient, Paul, who had an AHI of 33.5, well, Paul had tried a CPAP, so we want to have him fill out the affidavit of CPAP intolerance at someplace in our chart here. And then we tell Paul, hey, you're a good candidate to move forward. We do have a signed prescription from the sleep physician, in this case, actually the primary care physician, Dr. Namazi. So we've got basically all systems go. Paul, you're a good candidate. You're not wearing a CPAP. We can tell you that the oral appliance will reduce loud snoring in 90% of people. You look like you're a good candidate for that, and I know that one of your complaints was that your wife complains about your snoring. So would you like to get started? What are they going to say? I mean, the answer is almost invariably it's yes, okay? They are wanting what we do. So what is the next step then? Well, it's going to be an impressions and bite registration. So there's two ways to go. You can, go analog, okay? Traditional impression trays, and of course the bite registration to go with that. So that's one way to go. And doctors, if you are doing analog impressions, then you pretty much can do your bite registration. I like the George gauge. I think I've tried all the other different methods, and they're all sort of variations off the George gauge. So we use the George gauge. We can set the vertical dimension however we see fit for whatever we're trying to accomplish. So we'll use the George gauge. Doctors, if we're doing analog impressions, you can do your bite registration, basically delegate the impressioning to your auxiliary. In our case, her name is Lisa. Or in our practice, I'm a bit, or in any practice really, can you just loosen the cord from around the sink there, give me a little more slack there. Okay, in my practice, I'm a big proponent of digital. The reason I like digital is that it gives us unlimited storage of the models, okay? It also gives us distortion-free models. It also sets us apart because we're not putting that gooey polyvinyl impression material into a person's mouth to gag them and wait for it to set, and then they've got it stuck between their teeth, etc. So I do like digital very much, and then we can upload the image file to whatever laboratory that we want to, or we can secure the files and email them. So there's a variety of ways to go. The only thing to add, if you're going to be doing digital, is doctors, you may want to have the digital impressioning done and then come back in with the George gauge so that you're sure that it's positioned properly before the bite scan is done. So this is a digital impression. I think this is a Paul, a patient that we talked about. So those are the main steps. Nicole, did I leave anything off?
Absolutely not.
Okay, so you can see here, I took about 15 minutes doing this, but in reality, the amount of time that I'm spending in the in with my patient is maybe 5-10 minutes at the most. The beginning portions that I was showing you, going over the George gauge, going over how oral appliances work. Those sorts, talking to the patient, getting to know the patient, those sorts of things, they can be delegated to your auxiliary. I typically will come in for a new patient to meet them, go over their sleep studies. I'll perform the examination. It only takes a few minutes, and then give my blessing to the treatment plan, and then I'll come back after the digital impressions are secured to get the bite registration. As far as after that, we can talk about on subsequent talks. We'll talk about delivery, etc. But Nicole, come on in here, because I think what we need to do in our next visit is, okay, so we've got, move over just a little bit. Okay. So on our next visit with you, I think what we're going to do is talk about the money. Okay.
Absolutely.
That is an insurance, and there's some moving parts to that, and I think that's something that really vexes many offices when they're first starting with this. It's pretty simple. We've got it distilled down to a science. In my practice, I would say a patient is in here, 90% of the time we're proceeding with oral appliance therapy and getting paid for it. So I want to show you all how to do that. That will be our next topic next time. We'll be in a little more comfortable, spread out area, I hope. And then, until then, just remember, DSM Solutions, Add Water and Stir. Nicole will give you some information about how to contact us.
Yeah, absolutely. We'd love an opportunity to have a chat with every single one of you. If you would like to sign up for a complimentary practice consultation on our website, that website is dentalsleepapneatraining.com. You can always shoot us an email, info@dentalsleepapneatraining.com. Find us on Facebook at DSM Solutions, or find us on Instagram at DSM Solutions CA. And with that, we will talk to you next month. Looking forward to it. Everyone have a great day, and we'll talk to you later.
Bye-bye.